So John and science, it doesn't go together very well. So, there was a big discussion about telephones and cancer. And of course, this is the case. Shocking evidence. And John obviously would conclude this. Okay, good. Well, I almost get the impression that people fear me when I say something about evidence-based medicine. But it's, let me state clearly, the fact that if for a procedure there's no evidence doesn't mean that the procedure is not a valid procedure. It just means that we need to be slightly more cautious claiming, or at least forcing our opinion about it. A quick overview, I'm from Utrecht. Because of John only had a 5-minute talk, I need to speed up things. So, and yes, I do some research and some evidence-based medicine stuff as well. We're a group of friends, as you can see. And here you see Saji. He's the only one that doesn't look older now. And of course, me, a little bit fatter too. Robert, John, always his eyes closed. He always says he's tired. And this is the unique thing. We went to Brazil, to the World Conference, and John and this other guy were there too. And, they're amazed. They normally don't pay attention at all. And all of a sudden, this happens. And, of course, it had to do with this. And, we're all always well behaved. Someone gave me the video and wasn't aware that it was being videoed. So and it did put the sound off because it was quite insulting. But yes, we are. Anyway, we're friends. Yeah. Okay, good. So I do have to make a small deviation, and I try to keep everybody awake in the back, but I already saw some eyes shut. Talk a little about the procedure, the ear procedure. So in some extent, I do agree with Rob Briggs that maybe you should go the easy way. I mean, if you're not doing it frequently, maybe the easiest way is the best, but I don't know, we'll see. Being an expert opinion. Something about prosthesis type, surgeon experience, and lasers. And depending, because Robert, of course, we mixed now, mingled the program a little bit. It may be the case that I cannot finish the presentation if the patient is already sleeping. Okay, about the short deviation of otology. I think we should always be at least cautious and maybe critical of statements made, especially by John, claiming that things are such and such a way. So we should try at least to keep myth and truth apart. And for that, of course, you need to know where you look at the literature in an evidence-based way. I'm not claiming that I can, but anyway, I try. You need to know the relevance of the question, the risk of bias, and of course confounders. And confounders are nasty little critters that do change, seem to have effect on a certain treatment, and all of a sudden they are not independent of what you're measuring. And of course, I know Robert's luckily in the OR, but he always says, well, I don't need evidence-based medicine. They didn't do research on a parachute, and we all know it works. Well, actually, this guy doesn't know it anymore. So I'm giving you just an example. There was the American presidential election in 1938. And if you look at this sample size, any of us otologists or anybody in ENT would be jealous. Imagine that you had a sample size of 2.3 million samples to just predict the whole group. And they took, for the presidential election, they were asking, what are you going to do? And the answers, or what they did, of course, they took the phone books they had, car registration, and approached these people and said, what are you going to be voting? And with a sample size of 2.3 million on the whole group, you cannot go wrong, really. And this was what turned out to be the result from this poll that they did. Alf Landon was going to win, and he had a 55% lead over his competitor. But of course, nobody knows Alf Landon, so something went wrong here. Of course, the truth was, this was the result. Constituents, Rosenfeld blew Alf Landon out of the water. And one wonders, why does that happen? Why? Everybody knows this guy. So what went wrong? What happened was, of course, there was a great example of selection bias. They were looking at this American way, the new future. You see the happy family, even the dog out of the window, and this is the future of America. But the truth in 1936 was, of course, that this was America. People were standing in line for the food line. So if you ask people with cars and phones, you're asking only the happy few. So it's not a representative stake or test for the whole population. And if you are critical and you hear our constants, our questions and our answers, it's very similar to this. We present our data, I too, with a strong selection bias. You should at least assume that it is. So this was 1936, bad times. And to summarize, I hope you've seen this before. Of course, expert opinion, valuable, it's a basement, but it doesn't mean anything almost in the evidence-based medicine triangle, where of course we all would love to do systematic reviews, very tedious, but it's something to remember. And I'm not saying that if an expert says it's better to use a vein graft, it may be so, but I don't think there's a lot of proof to support it. That's what I'm saying. So if you look at the surgical procedure, there are a lot of variables. And if we don't standardize this procedure, I don't think anybody can claim that a nitinol prosthesis is better than a clip prosthesis, or a Teflon is better than whatever, a piece of bone. So you need to realize that if I multiply just these variations, general surgery or general anesthesia, local, you end up with lots of variations and nobody ever looked at it. And I don't think there are enough patients to really look at it anyway. So just let's look at pistons, because I did do some research on pistons. And I'm not claiming it was good research, but at least show something. There are many prostheses to choose from. The nitinol in Australia, very famous. I've been using this for a while. I stopped using it actually. I like this one. Robert does this one, and sometimes this. So many prostheses to choose from. And if you look, there's different materials, etc., etc. I'm just going to focus on two things: the crimping and the non-crimping prosthesis, and the diameter of the prosthesis. Nothing else. And to refresh your memory, crimping prostheses are the ones that you do need the small forceps to close, or what Robert does with the hooks. And some people describe this as the most complicated or difficult step in the whole procedure of stapedotomy. I don't agree. And this is another example. It's a clip prosthesis that you clip on to the incus. We compared these prostheses. So we know we have crimping prosthesis. Robert uses this one, the big loop, and non-crimping prosthesis. And we did a study where we looked at a considerable series, I think 120 patients or something. We looked at the clip prosthesis and the crimping prosthesis. And we found, and it was significant, and significant doesn't mean that much really, but we did see that the A-Wengen clip prosthesis had a better airbone cap closure on average than the crimping prosthesis. So one would suggest maybe nitinol, the same thing. Hooray, it's better than if you do it manually. However, the counter side to this was that patients did complain only in the clip prosthesis group about some distorted sounds. And we thought, oh, we found something, it's new. And I asked Robert to do a series, because he does lots of them, and do questionnaires on these patients if they had distorted sound. And none of his patients had ever had distorted sounds. So it's difficult to understand what's the cause of the distorted sound, but I do think eventually it's probably because the fixation is too tight to the incus, and the prosthesis seems to rub on the foot plate, which may not occur if you use a vein graft, but I think these prostheses are not as suited for vein graft compared to the Teflon ones. And we looked at the prosthesis diameter. And what we did a literature search, and we did it according to the evidence-based medicine theory, So you look at the domain, you look at the determinant, and you come up with a query, and you look at the literature. So we used PubMed, Embase, and Cochrane, the big laboratory databases. And in total, we found 1,455 articles that would be suitable for review. Of these, we found 310 which were deemed to be good. And of course, we did all the text survey, and we found which articles were good. In the end, we ended up with only 8 articles that were sufficiently written and designed to look at, take a closer look at it. And then you need to do a critical appraisal of what you're reading. And these are the domains that you look at. You look at relevance and risk of bias. And like I discussed with you, risk of bias is everywhere. If it's a selection bias, it's treatment bias, publication bias, you have to be very careful of what you're reading if it's really the truth. And if you critically appraise the journals or the publications that we had, you see that all of the publications had a medium risk of bias. And if you then would conclude what would be in the literature, there's no proof whatsoever that a bigger or a smaller prosthesis has any influence on the airborne gap closure. So anybody claiming, no, you shouldn't be using 0.4 but 0.6 has unpublished data, supposedly, or is an expert. We did work, and Manahar is here, we did some work on diameter on animal studies, and these do have seem to show, or no, it's laboratory, not animal, seem to show a slight benefit for a bigger prosthesis. But anyway, caution is relevant or wise to look at. And of course, surgeons' experience is very important. You see Robert does it very well, but if you learn it from a wrong surgeon, you may end up in trouble. So I wouldn't go, well, I'm not naming any names, but anyway, I wouldn't go to surgeons' colleagues, and I hope audio works. Audio, it doesn't. They're sleeping. Okay. That's a pity. I'll show you later. It's a funny movie. And then, of course, we did quite a bit of research on lasers. And we had a laboratory setup that we can see and measure the sound production, but also the heat production of lasers. And to give you an impression, this is a different type of laser, and I would advise you, although it's expert opinion, not to use any other than a fiber-delivered laser. This was during one of our live events, and I hear Robert Briggs laugh, and this is the incus. The incus was slightly trimmed, maybe to stabilize the fixation of the prosthesis. So I think that is the risk of through the microscope laser. You see any movement of the microscope puts you at risk. So laser-delivered, fiber-delivered lasers are best, I would say, or at least safer. And there are a couple of them. KTP, I think, is very often used. CO2, nice, because it does have some characteristics which are favorable. However, very expensive, especially the running cost for the CO2, the hollow fibers that you need. Diode, actually quite affordable, even battery operated. And thulium laser, which is in between the KTP and the CO2, is another laser that was very promising to use. Robert said something about being similar. KTP is here, and of course CO2 is good. And why CO2 is so favorable is the heat gets, or the laser beam gets absorbed in liquids. So you don't have a chance, if you shoot through the footplate, to hit the endoneurium, because all the heat is captured in the first layer of the watery perilymph. Thulium is supposedly to do the same, but we found it created a lot of bubbles, gas bubbles, in the inner ear. Diode and KTP are very similar. I think KTP works slightly better, but of course, economically, diode is a very good alternative. This is just a small video, and I'm not sure if it's going to work, where you see a laser beam being projected on the footplate, and you see the heat. I hope it works. It's always gas. Let's hope. Okay. Look here. There you see the heat. Underneath the foot plate once you go through it. This is safe. If you would do this with the KTP laser, you would see hitting it the endoneurium. And if you would do the thulium, you would see gas bubbles and explosions in the middle, making it not very suited laser for this kind of surgery. We looked at the sound production, and all the lasers have produced less sound than any burr or skeeter or osteostab. But there still is, you can still measure the explosions that occur at the foot plate. And if you look at the total sound production, you see that KTP produces the least sound in the frequencies that matter to us. That's the 16 kilohertz. And you see that microburr is way, way higher. Thulium and CO2 do make more. Whether this is clinically relevant, that's difficult to say. You know, I don't know. But at least we know there are definitely differences in the types of lasers and the effects that they have. Of course, we looked at the literature, doing the same procedure, looking critically at the literature, duplicates, languages, etc., and you end up with a couple of, with the question whether what the effect would be of a laser on hearing. And we do know that a laser will limit the chance of foot plate fracture, but none on the other domains there's any difference with any conventional surgery either. So anybody claiming that laser is per se better, which I, as an expert, would say it is, we have failed to prove it so far. We looked at different lasers and hearing, effect on hearing, and there are two publications that do show some difference. Robert Vincent and I think Neil published in a paper where we can see that the CO2 has a slightly better airborne gap closure, which I can't explain. I don't have an image. And there's an Italian group that semi-showed the same. But if you look at the quality of the studies, if I look at the quality of the study that we did, with Robert did with us, and the Italian, you should flag them off as not being adequate enough. So in general, all lasers limit the chance of mechanical trauma of the middle ear. The characteristics of the lasers are very important to realize because they do diode, very affordable, but does have some negatives. And thulium laser, which would seem to be the better laser, is not suited well for middle ear surgery. We did a series and we saw actually a higher central neural hearing loss group or patient number in the thulium group. So that's why we ceased using it. And I hope in the back, can someone wake him up, please? Is there, and John, can you moderate the questions? I'm happy that it worked. It's not the same question as last year, is it? Okay. Because I like to work on the sound. I like to show the video if I can. Hold on. Well, it was not a meta-analysis. It was Switzerland. It was from Switzerland, and it's well, it didn't even make the quality requirements of a critical appraisal. People coming from here will claim that vein graft is superior, which it is, I think. But anyway, yeah. So it was not a. I can name the name, but we're doing it live on the internet. So that study did not, and we looked at it honestly, and we couldn't support it.
I mean, we'll say the vein graft's superior, but we can't prove it. I mean, we can't prove it, or we haven't managed to prove it so far.
Yeah, I think that's the case, but it's definitely a more complicated surgery. So I think you should even stratify if you're an early surgeon or if you're a very experienced surgeon.
So how about my suggestion that if you're an early surgeon, you're more likely to drop the prosthesis in the vestibule, and the vein graft prevents that?
No, but I think it's a ludicrous expert opinion or statement. The thing is, if you don't do vein graft, you don't make a big perforation in the foot plate. And I've never had the prosthesis fall. I've dropped the prosthesis, but it never goes into the inner ear. If you make humongous, you do a platinectomy, really.
No, I don't.
And of course, if you, whatever you drop will come in. Yeah.
John, I'd suggest that just placing the vein graft through and trying to get it fitted, as Robert does so beautifully, to a small stapedotomy, that in itself is a difficult thing for a inexperienced surgeon to do. And so it may be that you're complicating the procedure by trying to put a vein graft and then put the prosthesis into the fenestra with the vein graft inside you.
Yeah, well, I can agree with that. But the other thing is that...
Can you hear the sound? John, hold on.
You must be the Dutch guy.
Relax, Max. Your nerves are just like jumping jacks, Max. Your heart is thumping with a crazy sound. Hear it pound. A bumping, 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 jumping up and down. Stay cool, fool. Just take it easy, that's the rule. The evening hasn't even started yet. So my pet, control yourself, don't get upset. So relax, Max. I hate to stop in your tracks, Max. But first you gotta prove your love to me. When you do, I'll love you like you want me to.
Anyway.
So, I mean, that's a very good point, but the other thing we haven't discussed is when you're a trainee doing this operation for the first time, I mean, most of us, I think with a vein graft, with a reasonably experienced surgeon, Robert is quick. I would say I'm somewhere between 30 and 45 minutes from start to finish. I don't know whether Chris thinks that's reasonable or... Is that about right? When you're starting, the first stapes you do, or the first 10 or 15, you may be an hour, hour and a half, and a lot of that time the foot plate's open as well. We could argue that putting the vein over straight away, which is what we do, is actually closing the stapedotomy over. I've got no evidence. Again, that makes any sense.
I mean, by the time you take to put the vein graft, I've got 3 prostheses in and dropped one.
Yeah, but you're an experienced surgeon. You're not an inexperienced trainee.
You're looking, you know, I'm convinced. I honestly, but it doesn't mean anything because it's expert opinion. I think a vein graft probably has better end hearing, because I do think you reconstruct some of the transformation and the elasticity maybe at the oval window.
That's hyperbole.
No, it is. But look at the results. The guys that I know that do vein graft, like Robert, has results that nobody meets, not even you.
But he's had quite a lot of experience.
So then experience is. I don't think experience is at all.
Experience is a major part of it, I'm sure.
I'm not sure. I think for that is yes, but I don't think for the end. Well, I think I don't know. Maybe you're right. Yeah.
Just one thing. What do you mean by dropping the
Means when you put the piston in. Into the vestibule, When you put the piston in, you miss the incus and it drops. No, I'm not saying that I do that, but I'm saying the vein graft prevents you doing that. And certainly with one of the other techniques you may see, which is when you're doing a total ossicular replacement, so a Stapes revision, you've got a much heavier prosthesis then. There is a significant risk.
That you can't do without.
Yeah. So, vein graft open, it's open to argument. I've got no use of vein graft. Having said that, what about the military? I mean, the CAA in several countries will not allow air crew to fly if they've had Stapes surgery without vein graft. So I think there's something.
In the rest of Europe, you can't fly a plane if you don't have the papers. And it's all anecdotal. The military doesn't know if you need a vein graft to be scuba diving or whatever. You know, nobody knows.
Well, if you-
I think that the appropriate message is that you've got to have a structured approach to sealing the oval window. And my approach, and I don't use vein graft, is that if you can make an accurate, nice fenestra, like Robert just did, then you should select a prosthesis that fits closely. For example, if you've done a 0.7 millimetre fenestra, then I use a 0.6 millimetre prosthesis, and I use a blood patch as a seal. And a blood patch. And that works extremely well. It's very reliable. Well, then, let me just explain. So if there's a partial stapedotomy or partial stapedectomy, for example, more of the footplate has come out for whatever reason than you want, or then I think it's appropriate to put pieces of tissue around the prosthesis. You don't need to put it under the prosthesis. And if you have more than half of a footplate missing or a total stapedotomy, then I like to completely seal the oval window with a tissue graft, either vein, fascia or perichondrium. And I suspect that, as Robert was saying, vein is actually too flimsy and flexible for that situation, and you may be better with perichondrium if the whole footplate is missing. But I think it's appropriate to have an algorithm that will work for you so you get a good seal and you're confident with what to do.
So I teach stapes surgery at the European Academy, and I start off the lecture and I go around the room and I ask people what they do, and they all do it differently, just like here. And I ask them why they do what they do, and generally it's because that's how they were taught to do it, and also because they get good results. So you do a nice small stapedotomy with your piston, you put a blood patch. Well, why do you put a blood patch? You've no idea whether that makes any difference. A lot of people do that without a blood patch. I
feel better doing it.
Yeah, and he feels better with his vein graft because he's always done it with a vein graft. And I started a study with Wilko. We randomised with and without a vein graft. And at the end of unfortunately for a variety of reasons, we stopped the study early. But at the end of the vein graft, at the end of the study, there's no difference between the two. And I'm sort of thinking, well, a vein graft is unquestionably more difficult. There is no question about that. And when you see trainees faffing around with the vein graft, getting it stuck on their sucker, caught on the corder, it's definitely more difficult. There's no question about that.
I've had patients complain about
the thing on that back of the hand, or it heals usually well. But so then you sort of think, well, actually, I do use a vein graft. Why am I doing it? Because the results are no different. And then you begin to think, well, maybe it's that 1 in 200 that gets the dead ear. Maybe they're more likely. And we don't know. And we're not likely to know because the numbers you require to see those differences are so huge. We'll probably never know. So with the self-crimping prosthesis, I've used that. Quite like it. Haven't seen any difference in my results. But then I sort of think, well, if it crimps with the nitinol, what's the chance of getting late incus necrosis? I know with my own series that I get a 1 in 200 late necrosis over 20 years. That's pretty small. What if somebody said to me, well, you can use a self-crimping prosthesis and it'll give you on average 2 decibels better air bone closure, but in 10 years your necrosis rate will go up from 0.2% to 1%. So these are the questions that are really difficult to answer. And what happens is people have a technique that they like and that works for them. And I think that's probably okay. I think we're going to struggle to come to this meeting in 10 years and say, this is the best technique. I think it'll be difficult.
But I do think that having an adequate seal at the footplate is important.
Yeah, you think that?
Yeah.
But you don't know that.
Well, no, it's observational, but...
No, it's not.
Comparing...
You've never not done it.
I personally haven't done it, but I have seen total stapedectomy done without a seal.
Rob,
and they're very, very, very dizzy, those patients.
We're all in the race like this, and please see it as all expert opinion, which it is.
No, I think there are some things that are true. There's no question that
when you see expert opinion.
No, this is not. This is not expert opinion. If you see a patient and they come and see you, and you say, "We're going to do your operation. It's a day case." You go home on the day of the surgery, and they say, "Well, I had my other one done 20 years ago, and I was in hospital for a week vomiting." That's a very common story from the guys who used to have a total platinectomy. There's no question that the microstapedotomy makes them less dizzy. absolutely. I think that's not expert opinion.
It is observational. Yeah.
Yeah, but it's a very, you know,
I'm with you,
it's
Chris.
my observation, and it's definitely right.
We're never going to answer this question about veins or not veins. We just have to have so many cases to do it. I've got an incredibly simplistic approach about it, and that's I wanted to be an engineer, not a surgeon. And it strikes me for the last 120 years, engineers have been struggling to reduce the clearance between pistons and cylinders and put decent cylinder head gaskets on to prevent leakage of oil.
It's not a piston-driven motor we're talking
I know
about
it isn't.
here.
I know it isn't, but I bet if we got a fluid engineer in here, we could have some really interesting discussions about this. But we're still not going to prove, because the number of patients required to prove is in the tens of thousands.
But what does happen is that the endosteum rapidly reforms and creates that seal around your piston.
Yeah. Okay.